Okay, so yeah, my name is Wayne Clifford. I've been in public health for a little over 30 years, and in all that time, this is the first time I've ever been involved in something like this. And I started on the incident management team for the State Department of Health in April, and the branch that I'm serving in is called Medical Surge. And I'll talk a little bit about the overall mission of Medical Surge, and then specifically um, our work around isolation and quarantine. So the basic components of the Medical Surge branch are, as I mentioned, isolation and quarantine, and that is a way for the state to help relieve patient load from hospitals during the pandemic. So in hospital terms, they talked about surge, and surge means that their beds are filling up, and sometimes they get into an overflow. Most hospitals have a surge plan in place to in case of mass casualty or something like this, or the pandemic, and they will exercise those plans, but they can reach overflow capacity. As I'm sure if you've watched this play out internationally in places like Italy, where people were literally dying on the streets and the hospitals were completely uh, incapable of keeping up with patients. So isolation is a form of alternate care. It's not, they are not isolation facilities, or not medically licensed facilities, but they're places where because they're sick or they tested positive, and so they're also referred to as alternate care facilities, and they're predominantly for people who are displaced. And so within Medical Surge branch, we also monitor, we have fatality management, where we actually keep in touch with the undertakers within the state to monitor their capability and things like this. And then we have also some more work around having a state facility to support isolation. Response is here the increasing use of external resources. When we work with local government, is to enable their local capacity, provide technical assistance, and help them solve their problem locally. At the next level, when the risk starts increasing, we provide more assistance in a regional fashion to provide technical assistance and have our isolation strike team working closely, working local regional capacity by bringing in extra resources at the very top level. We're providing a state-run isolation and quarantine facility through our emergency isolation plan. So there's a couple of versions of when I say strike team. One is the technical assistance strike team that goes out. It's 2 to 4 of us go out, and we actually get on the ground with the county, and we look at what they have. We help them work through their problems and try and help them with their to address it at the local level. Then the other strike team is it's a surge strike, and that's where we bring in up to 30 beds, and we can set them up in a facility and help the county when they become overloaded. So I'll talk a little bit about that surge capacity or that surge support, but to help you understand the difference between isolation and quarantine, this is a flow chart that represents people in the orange boxes on the right and left who, on the right-hand side, CLS is COVID-like symptoms. So somebody is symptomatic, they self-report into the hospital does testing, and if they test negative, they go into what we call a non-COVID disposition. And so it's some other outcome. It might be the flu or something else. If they're COVID positive, but they're not critical, then the hospital has the option to send them to an isolation facility where they're monitored by medical staff, but they're not in an actual hospital. If anybody in isolation becomes critical, there's certain things that are monitored in there that will be triggers for saying this person really does need to get hospitalized, and they could end up on a ventilator, and they could end up in the ICU with intensive care. So that is one route. Then we have on the left-hand side, you just have a positive case, and each of these positive cases in the best model is that they do contact tracing. That person, of course, can go to isolation, and but the contact tracing should identify people who they've come in close contact with, who have the risk of contracting or becoming infective to other people. And so people who have positive contact with that person, we don't know if they're actually infected, but they'll go into quarantine. And quarantine is a lower level of medical oversight, but it's a higher level of it's actually a higher level of isolation than isolation is, and you'll see why in a minute. If they become symptomatic while they're in quarantine, they should go into isolation, and or if they test negative, in quarantine they'll be being tested. So if they test negative, then they're free to go isolation. So all of this is designed around this box that says hospital surge. So it's to maintain critical capacity in the hospitals and offload people who don't actually need hospitalization. They might have just mild symptoms. So this diagram shows just the basic fundamental differences between people in quarantine and people in isolation. So on the right-hand side, you have a representation of what would be an isolation facility. It's shared airspace, it's partitioned beds in a big room. These people are already infected. We're not worried about them infecting other people, other than the people who are taking care of them have appropriate personal protective equipment, and there'll be nursing staff, that kind of thing. So we call this cohorting. We put them all together, and we can put them together in the same room, and they all get monitored regularly. And these are typically facilities that be placed or identified close to a hospital, so that they can be transported if somebody starts to crash within about 20 minutes. Then on the left-hand side, you have the people what's represented there is people who are in quarantine. So if you think about your old style Motel 6, it has all exterior doors, independent air supply, the air conditioners that hang outside the rooms, and this kind of thing. These would be individual people who we don't know if they're positive yet. We suspect that they've been exposed, and so they'll be in quarantine, isolated from everyone else until they're tested or until they're 14 days without symptoms. And so this is the fundamental difference for the purpose of public health in this pandemic response. These are the definitions that we use for isolation and quarantine. If you talk to a hospital or an emergency room, they're going to give you a different definition for medical isolation and quarantine. So again, thinking about our strike team concept, on the right there is sort of a representation of how we are prepared and how we operate. At the first indication that that we might be asked to actually surge support a hospital system, we send an advance party. They deploy probably within hours to go out and start meeting with get on the ground, meet with the county, take a look at what the situation is. And again, the goal there is to help that county solve the problem themselves first. And then if they can't, the advance party then contacts the main body, what we call the main body back here in our warehouse. And we literally have these trucks and trailers loaded up with beds and partitions and supplies to go set up a isolation facility up to 30 beds per strike team. Now, to keep us informed about how hospitals are doing, we have these dashboards, and you can see a lot of tabs across the bottom for different aspects of hospital surge. And so we monitor these on a regular basis. Data's coming into them, and we can tell county by county how they're doing, and if there's indicators that we should check with the county emergency management to see if they have hospitals that are needing support. The hospital networks themselves help the hospitals a lot with moving patients from one hospital to another to relieve surge. But these are some of our indicators that we monitor on a regular basis. And then for isolation and quarantine itself, we have a similar type of dashboard where we do a weekly survey of counties with isolation facilities to see how their isolation load is. And this is another indicator for us that if the hospitals are getting overloaded and their isolation facilities are getting overloaded, then we at the state level should be prepared to go support that county. Now, getting into our operations, we do have National Guard support. We have our Air Guard and Army Guard deployed with us. And so they can provide rapid air transportation to get supplies and team members out into the areas of our state. And what you see there is a Black Hawk helicopter. And so we're getting to understand the operation of a Black Hawk pretty well. It's an interesting part of the operation. What you see there strapped down in boxes inside the Black Hawk are ventilators that we're delivering out to support hospitals. And we've also been out doing consultation with our state correctional facilities, helping them with inmate population and helping them to plan for isolation and quarantine in their facilities. So I'm happy to say this was my first time looking at the insides of prisons. And then this is just an interesting shot. One of the buildings that we looked at was a closed down solitary confinement wing in a women's hospital. And so you can imagine these are the facilities that women who were placed in solitary confinement would live in and get their meals through the door. And the sink is literally right above the toilet in here. But needless to say, that's shut down. And they were thinking, could we renovate this to be a complete isolation wing? So when you think about commercial facilities, when we look at them like prisons or like long-term care facilities, we look at what are the routes of infection coming into the facility. And typically you have these 4 types, and inmates is particular to prisons. But so we talk to them, okay, have you closed down your visitors? Well, most long-term care have stopped visitation. Prisons have stopped visitation. So that cuts off one of the routes of infection. Then you have to have supplies. So you have vendors coming in. Well, the vendors can be controlled by having them not get out of their truck, stop at the loading dock, have people there in the facility who unload. And that way, if there's drivers on board that might be asymptomatic infected, you don't know. So that keeps them away. And then for the prisons, the inmates themselves they have complete control over them. So they can, when the new inmate comes in, they go into a quarantine wing where they're gonna stay for 14 days or longer till the prison is sure that they're not infected and they're not at risk. So what's left is the staff, and the staff come and go. The staff in long-term care sometimes visit multiple facilities. They go out into the population, into the community, and we don't know really what their behavior is like out there, if they're really practicing safe practices or not. But some of the routes of infection for prisons and for long-term care have been from staff members. So this means that they have to increase the level of education and requirements on their staff so that they can reduce that risk and try and stop the spread from their staff members coming in. So we've spent a lot of time, a lot of visits with county, local emergency management, and local public health. And this building is kind of an example of something that they came up with, and they want us to come in and say, hey, how could we make this work? What would we have to do here? Will it work as isolation? Will it work as quarantine? And some of the things we find and these 2 buildings exactly the same, and they thought that they could quarantine in one and isolate in the other. As you remember the diagram before, there was no ability to separate people from each other. Think about something else. And many of them, the counties have units, parts or types of things for quarantine. And then, we get these floor plans and help them look at how could we make say a high school gymnasium actually work as an isolation facility. And then Washington has several recognized tribes, federally recognized tribes, and they're sovereign nations, and so they don't typically work directly with the state government. They typically work directly with the federal, but they have, we've had just about all of them have contacted us to come out and take a look at their facilities and help them understand the same problems that the rest of their community is facing. And so what you see there is one of the beds from their isolation facilities, and some of their buildings that they're looking at and asking us, so how can we make this work? And some of the solutions, as I mentioned, that the counties come up with are these hotels that weren't really seeing a big tourism industry. So the county would lease the hotel on a month-by-month basis, and then there's some we looked at some group camps, Bible camps, or other types of group camps where they have cabins and these types of things. So the solutions that counties are coming up with are widely varied, and like we have 39 counties, and we see 39 different solutions as we go around the state. And one of the challenges with this is that all of these facilities are owned by someone else. The counties are, in some cases, it's beg, borrow, or steal, just trying to come up with adequate facilities to be prepared for taking in people for isolation and quarantine. So our challenge in the public health system is that these types of facilities are not in our infrastructure. We have lots of offices and places where people work, but we don't have these types of buildings in public health infrastructure that we can just activate and know that they're there. We have to go out and negotiate and have contracts and leases and things like this. So it's an incredible amount of work, and it's a large expense of tax dollars going towards trying to maintain this capability. And this is typically another typical example of what we might start looking at. County fairgrounds and county, we got all these big exhibit buildings, and they're not being used, and the fair isn't happening, and so the county has a little more control over these. And the picture on top is one of the typical things that we look at, which is the ventilation system. When you're looking at having people, infected people in a big building, and then you have staff members in another part of the building who are going to be going in and taking care of those people, you have to have the ventilation systems have to be separated. So we look a lot at, first thing is like HVAC and what needs to be done. If it's all shared airspace, we start recommending HEPA filters get installed in the vents, and taking a look at what are the solutions, how can we make this work. But shared air is one of the critical areas that we focus on. And this building was used, that building that I just showed you was used for an exercise. I'll come back to it. And now our other big issue here in Washington State, we have a lot of agriculture. Our state is divided in half by mountain range, and on the east side is arid, lots of sunshine, lots of irrigation, lots of farming, and we are in what's known as the Western Migrant Stream. So the migrant farm workers are here now. They're up helping with harvest, and these are a couple of examples of migrant, what we call temporary worker housing or migrant farm worker housing. We have rules in place at the state laws that govern the structures that can be either these fixed constructed wood structures, or they can be the tent type structures. And so people, the families will come up, and the adults are working and somebody's taking care of the kids, and so we have whole families moving through the state. And with that comes outbreaks of infection within these camps and within the housing and within the worker population. And so we are seeing that happen right now. And we're actually reaching out, working directly with the companies, the agricultural employers, to help them understand isolation and quarantine, and maybe help them plan for how they're going to manage a workforce to reduce the risk of spread and maintain their operation and still get our food, keep food going in our food supply. So this is a really critical piece of infrastructure. So this is, moving to this is some pictures from an actual operating isolation and quarantine center that's up in one of our larger counties, big urban county, Snohomish up north. And so you can see the partitions, and there were actually people in here that had become infected and they had no place else to go. So this becomes their living environment while they're working through it. And then you can see down here, they've got the animal carriers. They worked out an arrangement with the local animal shelter to help provide veterinary care for pets and things like this. The pets are really important to people, and maintaining their mental health and those types of things when they're going through this is really important. So they try and allow them to walk around in here, but they're kept inside there. This building was very large and had large garage style doors, and so they would open the doors about a foot or two, and their ventilation system up on top was reversed, so it's pulling air in from outside and venting it out the top. And so they created an airflow that really eliminated the risk of infection from airborne virus. Now I mentioned strike team, and so this is what the medical surge branch here I mentioned is prepared to do. This is a medical surge strike, and this is from our exercise that we did. And so you can see we went into that fair building and we figured out, well, there's really no place for nurses to get in and out of their PPE. So what you're seeing constructed there is a makeshift donning and doffing area. That's what we call it when they put on PPE or they take off PPE. They either don it or they doff it. And they have to have an isolated area to do that. And then the trailer there is backed into the front to the door. We're starting to unload the partitions, and these beds down here that you see getting put together are all folded up. They're called emergency beds, and we roll them in. We're ready to set up this isolation facility. So when it's all done, this is what we set up, and we then prepare the county to take over operations. We change out these emergency beds, which are not quite as comfortable, with actual hospital beds. And then we load those beds back up in the trailers. We leave the county with the partitions, the hospital beds, and all the supplies. And so we're prepared to operate this for 48 hours, probably up to a week if we had to, while the county gets all their contracts and things in place to take over the operation. So a lot of the things that we help the counties think through is what we call wraparound services. And if you think about, setting something up where people are going to have to live while they're sick, you've got all of a sudden we're going to bring food in, provide laundry service. Is there adequate power and electricity within the building? Give them some entertainment. It's not jail. It's an alternate care. So we want them to be as comfortable as possible. They might have an outdoor area to go to sit at a picnic table so they can get outside. They can have site security to prevent unaware people from wandering in or anything else. So they're typically fenced off with a security guard. In the garbage service, when you're dealing with infected patients, the garbage and that type of stuff takes on a different dimension. So, and then make sure your EMS system is aware that facility is operating and that you got people there, and maintaining that good communication with EMS so that they know what your load is. and in case you need to call them, they know that they're coming to a COVID isolation center. And then your basic contracting for cleaning and sanitation. So this is my own personal story around quarantine. I was up on a fishing trip and had taken a few days off from this work. And the day after I got up there, I got a text message that one of our team members was home, was running a fever, and we were starting to internally starting to react to that in terms of, so what do we do now? The team member was being tested, and so we're all in a holding pattern about, can we come, because we do all work in the same space in the warehouse here. And so my fishing friend's wife agreed to drive up and transport them back home. And I said, I should isolate myself from you, and I should go back in my truck, and my truck was the only one there. So she came up. When she arrived, she had created a quarantine area in the back of the truck with, you see the colorful duct tape and Bisquick. And she said, you guys are going to sit in the back of this truck, you're going to keep the windows rolled down, and you're going to be in quarantine on the ride home. So that became quite a topic of conversation. So I drove back by myself, and they got transported back in the back seat of this quarantine. But in the end, the trip was worth it. So that's what I do for my spare time. So that brings me to conclusion, and I know that was a lot of information, but I'm happy to take any questions.
All right, we do have one question that was asked in the chat section. Says, what do we do if someone is diagnosed mildly symptomatic and then their test comes back negative? Do we allow them to come back to work, or do they continue to quarantine 10 days from onset of symptoms and meet other CDC criteria for going back to work?
Well, it's going to depend on your local jurisdiction's rules, but I know there is CDC guidance out there about priority workers and when they can go back to work. But if someone is symptomatic with COVID-like symptoms and they test negative, the problem that we have with testing is the sensitivity of the test. And so you definitely want to talk with your local health department about what type of test it is, and it's going to depend on what type of test. But some of the tests, the sensitivity is so low that we really don't get confidence in the negatives until we get 2 or 3 tests that are 3 days apart. So in some of the jurisdictions are going with 2 tests. If you're two negative tests, then they consider you negative. So that's part of the system right now that there's uncertainty around. But it's really going to be something you'd want to connect with your local health department and talk to them about.
All right, we've got 2 last questions, and then we've got to wrap it up for the general session that will be starting here in about 10 minutes. But the first one is any recommendations on whether employees traveling by air to be self-quarantined upon return, including duration of quarantine if recommended?
So I am not sure what our agency, if they have a policy around air travel. You know, if you think about where we're at in this pandemic right now. People are going to the grocery store, they're wearing masks, they're keeping the social distancing, and I think the airlines are responding to it. It really comes down to people's personal behavior and whether or not they're following that when they're wherever they've been. If they've been to another country and they've been on vacation and they're in bars and things like that, they're running a lot higher risk of bringing back infection than if they've been on a business trip where everybody is social distancing and wearing masks and behaving. So these are tough questions that again, I would really check with your local state major airports. You know, CDC has quarantine stations at most major terminals, and they're probably they may be monitoring people that come in off of these flights. That's one of their jobs. That's probably not helping a whole lot, but there is so much of this that is about personal behavior and not so much about, like, I was on a flight where I was in a van, or I was at someone's house, because it depends on how much that person is actually protecting themselves.
So we have time for just one last question. Just as a reminder to everyone, Wayne's email, which you see on the screen, is also on his profile page. You feel free to ask him any questions that come up. But why are healthcare members getting COVID even though they're using all this extra protection?
Well, now I don't know if they're using high levels of protection, like we have what we call PAPRs. They're the big white hoods that go over people's heads with the screen in front. The plastic screen effect. A lot of nursing staff will wear surgical masks, and they're very similar to the cloth masks that you see me wearing there. They're not really personal protective equipment. They're there to keep my particles contained in sort of a close area around me.
All right, Wayne, you're kind of breaking up a little bit, but we all want to give you a, go ahead.
I think in the beginning scene where viral load. So I think that they've been exposed to lots and lots of people who are highly infectious. So their risk just goes up of, you know, they let something slip. They do something that all of a sudden gives them an exposure. Their mask isn't tight enough, or it's not fitted properly. So there's a number of reasons, but it would come down to personal, you know, really, if you're wearing good personal protection and it fits well, you shouldn't be getting infected.